Okay, we are going to talk about uveitis here. We're going to briefly touch on some anatomy, just because the eye is not a very common place to deal with problems, especially if you're an internist or a pediatrician or you work in the ED. It's important to know the intimate structure of the eye when we're talking about a topic as complex as uveitis. So we'll briefly recap some of the anatomy that may be rusty. We'll talk about some basic definitions, really pin down what the uvea is, what it does, what it's responsible for, and what can happen if something goes wrong with it, primarily if it's inflamed. We'll talk about the types of uveitis, the clinical picture, how you can distinguish anterior from intermediate from posterior uveitis, and then how to work these up. Panuveitis we're not going to talk about as much, just because it's a combination of the three of these, because the entire uvea is inflamed. Then we'll talk about treatment. So if you were to look at the eye from the side, slice it right down the middle, this is what you would have. So you've got three chambers: an anterior chamber, a posterior chamber, and then a vitreous chamber. And they're not the same. So the anterior and posterior chamber have aqueous humor, and then the vitreous chamber has vitreous humor. The uvea is three parts. It's the iris, it's the ciliary body right here, and then it is also the choroid. And the choroid provides a base for the retina. It also provides a medium for the transport of nutrients and waste products. And the choroid is very highly vascular, so that's useful when it comes to providing nutrients and getting rid of waste products. So as you can see here, the uvea it is not just one discrete organ of the eye, as the lens is, or as the iris alone is, or as the cornea is. It extends from the anterior aspect of the globe all the way to the posterior aspect of the globe at the optic nerve. So this is a very profound structure, and the symptoms of uveitis can vary based on where the uveitis is. If you were to look at the top of the globe, sliced down the middle, this is what you would see. So it's a little easier to see the chambers here: your anterior chamber, your posterior chamber, and your vitreous chamber. The anterior chamber is bordered by the cornea anteriorly, and the anterior part of the iris posteriorly. The posterior chamber is bordered by the posterior part of your iris anteriorly, and the lens and the ciliary body posteriorly. So note that the ciliary body here contains the suspensory ligaments and zonial fibers, and those are responsible for holding the lens in place as well as changing the shape of the lens. So if you look at the anterior chamber a little bit more closely, you have Schlemm's canal and the angle of the anterior chamber. Those are clinically of paramount importance, because if these were to become blocked, as they do in acute angle closure glaucoma, or as they could in anterior uveitis, you will not be able to drain aqueous. And if you're producing aqueous, well, you have to have a way of draining it too. Otherwise, the intraocular pressure is going to go up, and that can have devastating consequences on the patient if it is not detected. So this is an important structure here. And when we're talking about uveitis, the treatment of uveitis is primarily done by an ophthalmologist, but you are responsible for identifying uveitis, and that's what you're going to be responsible for on boards. So the uvea, as mentioned, is a pigmented vascular structure that consists of the iris, the ciliary body, and the choroid. The iris is the anterior part of the uvea. It's got many different components: vasculature, musculature, melanocytes, and melanocytes are what gives your eye its color. It's got nerves that provide the musculature, its innervation, clump cells, collagen, and mucopolysaccharides. There's two very clinically significant muscles, and these muscles are what change the size of the pupil. So the pupil is just the aperture of the iris. So you've got the sphincter pupillae, and as its name would imply, this is what constricts the pupil, reduces the aperture, and this is receives innervation from the short ciliary nerve, and this is parasympathetic. So parasympathetic innervation constricts the pupil. And the reasons you would want to constrict the pupil would be, for instance, in response to light stimulation. If you go outside and it's sunny out, you don't want to get all that light into the back of your eye and onto your retina, because that would be damaging. It also constricts when you need to accommodate. So when you're looking at something close up, you actually want less light to come into your eye, because if there's less light coming into your eye, it's actually going to project the image more anteriorly, and that's useful when you're looking at things close up. So this helps with accommodation. So as mentioned, this receives its innervation from the short ciliary nerve. Ultimately, those fibers come from the third cranial nerve. The iris dilator gets sympathetic innervation, and this dilates the pupil in response to sympathetic innervation, and that comes from the long ciliary nerve, ultimately which comes from the ophthalmic branch of the trigeminal nerve. And these are just sympathetic nerves. Then you've got vasculature in your iris as well. This is formed by both anterior and posterior ciliary arteries, which come together and form sort of a circular arcade. The ciliary body is a multifunctional, multi-layered tissue which extends from the ora serrata posteriorly to the iris anteriorly. And there's three major parts when we're thinking about the ciliary body, both anatomically and clinically. So you have the pars plicata, which is the most anterior layer. It contains vasculature, as well as those zonual fibers, which connect the ciliary body to the lens and allows the ciliary body to manipulate the shape of the lens, as well as hold the lens in place. The vasculature in the pars plicata regulates aqueous humor production, and that's also where you get your aqueous humor from. So it's just fluid coming out of the vasculature right there. And that's important when we think of anterior and possibly intermediate uveitis, because if you get a pathology of that vasculature and a breakdown of that blood-aqueous barrier, you can get proteins and other abnormal components into the aqueous humor, and that can cause symptoms. The ciliary musculature is associated with the pars plicata. Its contraction pulls the lens in an anterior direction, and that makes it more spherical. So here's your lens here. When the ciliary muscle contracts, your lens is going to become more spherical, more circular. And that increases the refractory index of the lens. And so by doing that, it is going to project the image more anteriorly. And that is good, again, for accommodation. So in addition to constricting the pupil, which is done by parasympathetic nerves, you also have parasympathetic nerves, the same nerves, short ciliary nerves, that will constrict the ciliary muscles and make the lens more spherical and provide for accommodation. The ciliary musculature, when contracted, also increases the size of the pores in the trabecular meshwork. The pars plana is the middle posterior layer, and it secretes mucopolysaccharide, and that's a key component of the vitreous humor. So in a nutshell, you have parasympathetic tone to the iris and to the ciliary musculature, and so parasympathetic tone by the short ciliary nerves will constrict the pupil size by activating the sphincter pupillae muscle. It will make the lens more spherical, and that's via the ciliary muscle, and it also increases the size of the trabecular meshwork pores. On the counter end to that, sympathetic tone dilates the pupil via the pupil dilator muscle and the long ciliary nerves. It makes the lens flatter by relaxing the ciliary muscle, and it decreases the size of the trabecular meshwork pores. And so this parasympathetic tone is very important for accommodation. The short ciliary nerves is what allows you to constrict the pupil size and make the lens more spherical. Both of those are responsible for accommodation. So when you think about it, You go to the eye doctor and they want to get a good look at your retina. They give you something to dilate your pupil. And what they give you is usually something like tropicamide, which is an anticholinergic, meaning it works against acetylcholine. It's a sympathomimetic. So it works against the parasympathetic tone, and that allows you to dilate the pupil size, but it also makes your lens flatter. You can't, your ciliary muscle is paralyzed. We call that cycloplegia. And so when you come out of the eye doctor, they give you those sunglass things, so sunglasses, so that when you go outside into the sunlight, because you can't constrict your pupil size, you don't want to damage your retina. And if you try to read a newspaper, you're not going to be able to because you cannot accommodate properly. Not only because you can't constrict your pupil size, but because the ciliary muscle cannot make your lens more spherical and hence cannot accommodate. Okay, so the choroid is a vascular layer between the retina and the sclera, and it extends from the scleral spur to the optic nerve posteriorly, and this provides nourishment and waste removal for the outer layer of the retina. And so there's multiple layers of the choroid. Don't memorize these, just know there's multiple layers and they're primarily vascularized. And so working from inner to outer, we have a basement membrane of the retinal pigment epithelium, going all the way to the basement membrane of your choriocapillaris. This is Bruch's membrane. And then you also have a choriocapillaris, which is small vessels, Sattler's and Haller's layer, which are medium and large size vessels respectively. So this is the choroid, and it's primarily vascular, and it allows for nourishment and waste removal for the outer layer of the retina. Okay, so talking about uveitis. You can have anterior uveitis. Anterior uveitis affects the anterior chamber, the iris, and the anterior ciliary body. There's intermediate uveitis. Intermediate uveitis affects the vitreous, the posterior ciliary body, and the peripheral anterior retina. There's posterior uveitis. This affects the choroid and the retina. And then finally there's panuveitis, and this affects all parts of the uvea. And now I know the retina is not part of the uvea, but because the retina is so intimately associated with the choroid, when you have inflammation of the choroid, it many times leads to inflammation of the retina. And so that's why I included the retina here. So uveitis is inflammation of the structures of the uvea, which can result in eye pain, photophobia, change of vision, decreased visual acuity, and other symptoms. And the symptoms and clinical findings are going to depend on the location of the uveitis. So anterior uveitis, which is by far the most common form of uveitis, makes up about 60 to 90% of cases. Primarily this is affecting the anterior chamber, the aqueous chamber. Intermediate uveitis affects the lens, the posterior chamber, the ciliary body. That makes up the minority of cases, about 4 to 8% of cases. Posterior uveitis affects the choroid and the retina. That makes up about 15 to 22% of cases. Panuveitis, I couldn't get a number on, but it's probably somewhere in between posterior uveitis and intermediate uveitis. So more common than intermediate uveitis, but less common than posterior uveitis. The number one cause of uveitis overall, if you were to combine all of these, is idiopathic. We don't know the cause. But infectious and autoimmune cases are primarily what the cause is when we don't know what the or when we do know what the cause is. It's usually an infectious source or some kind of autoimmune source. So here are the common causes of uveitis. You don't necessarily need to memorize these, but there are some things that are worth remembering. So when it comes to infectious causes, TB and syphilis can cause any kind of uveitis, and they're among the more common infectious causes of uveitis. Lyme's disease can cause intermediate uveitis. Bartonella, which is your cat scratch fever, can cause posterior uveitis, as well as toxoplasmosis and toxocariasis, which can also cause retinitis. Herpes viruses can cause anterior uveitis. They can also cause posterior uveitis in the form of ARN and PORN, which we talked about in the retinitis section. Anterior uveitis can also be caused by the seronegative spondyloarthropathies, which primarily consist of ankylosing spondylitis, psoriatic arthritis, Reiter syndrome, and acute anterior uveitis, which is a very common cause of anterior uveitis. And then juvenile rheumatoid arthritis. Multiple sclerosis can cause intermediate uveitis, and then there's a lot of these weird causes of uveitis on the posterior and in the panuveitis side, which we'll talk about a little bit. This isn't going to be a very commonly tested area on the USMLE, but this will help you get your 99 percentile points if you really want those. But the big thing to remember is the seronegative spondyloarthropathies, especially AAU, psoriatic arthritis, ankylosing spondylitis, being associated with anterior uveitis, because this is the most common one, as well as TB and syphilis being associated with any of the uveitises. Okay. So, anterior uveitis I wanted to give the most attention to because this is the most common form of uveitis. This is an inflammation of the anterior uvea, being the iris, and this anterior ciliary body, and this can be, as mentioned, idiopathic, immune, or infectious. It's the most common form of uveitis. The exact pathophysiology is unknown. You can have acute anterior uveitis, and this is an umbrella term. This can be part of an immune process. But because we don't know exactly what causes it, when you have idiopathic anterior uveitis, it's usually because of acute anterior uveitis. So it's an umbrella term, but it can also refer to a specific pathophysiologic process. The only problem is we don't know exactly what causes it. We don't know the pathophysiology behind it. Immune-mediated anterior uveitis can be caused by ankylosing spondylitis and psoriatic arthritis very commonly. Can also be caused by inflammatory bowel disease, by juvenile rheumatoid arthritis, and also by sarcoidosis. A lot of patients that have sarcoidosis will go on to develop anterior uveitis, around half. So if you have ankylosing spondylitis, psoriatic arthritis, your chances of developing anterior uveitis are there, but they're not as high as if you have sarcoidosis. Sarcoidosis, if you have it, you are very likely to develop anterior uveitis at some point in your life. And then the infectious causes, syphilis and TB, as go for all the uveitises, as well as herpes simplex virus and varicella zoster virus. So symptomatically, with anterior uveitis, and this is in contrast to the other uveitises, intermediate and posterior, the patient will present with a painful red eye. So you have a painful red eye, very exquisitely painful, sensitive to light, photophobia. So this patient will want to be in a dark room. They'll also have red eye and it will be painful. And that is going to be in contrast to something like conjunctivitis, where in conjunctivitis you have a red eye, but it's more irritated, not so much painful. The acuity of the eye can be reduced, but it's not drastic. There can be external symptoms as well, like tearing, lid puffiness, and eyelid drooping. You can also see abnormalities of the iris and the pupil, such as synechiae. Synechiae are particularly, posterior synechiae are where you have adhesions of the iris to the lens, and that can be really problematic if you have enough of them. So we want to get rid of these, and that's going to be part of treatment. And then these iris nodules are more of a clinical sign that pushes you towards a possible diagnosis of anterior uveitis. We'll look at some of those in a little bit. Also, the pupil can react sluggishly, and that makes sense because you have inflammation in that area along the iris. The iris is responsible for changing the pupil size, and so the pupil can react sluggishly. The differential here, as mentioned, includes conjunctivitis. That tends to be more of an irritated red eye, not so much painful. Acute angle closure glaucoma, typically you're going to have a blown pupil in that case, and then keratitis and scleritis can be difficult to differentiate. Usually the ophthalmologist will have to do that. But you certainly won't have synechiae in keratitis or scleritis. You shouldn't. Okay, so here is what those synechiae look like. They're just extensions of the iris, adhesions of the iris onto the lens, which you can't see the lens, but you can see the adhesion of the iris, and that's synechiae. One synechia, two synechiae. It's plural. Here you can see a little less dramatically, but you can still see synechiae here. And here's some more. So what this can also be called is a festooned pupil, and when you have enough synechiae, it really increases your risk of pupil block glaucoma. These are called Kepi nodules. And so you see this along the inner margins of the iris, and these are associated with anterior uveitis. So when you're diagnosing or making a diagnosis, coming to a diagnosis, the history and physical are going to be important because some of the processes that lead to anterior uveitis are systemic, like inflammatory bowel disease, where the patient may complain of abnormal bowel habits, diarrhea, blood in the stool, ankylosing spondylitis, where the patient may complain of stiffness in the back, psoriatic arthritis, where you have skin lesions, recurrent skin lesions. All of these are associated with anterior uveitis. And so if any of these are present, you want to know, because if they are present, it definitely is going to increase the likelihood of anterior uveitis being the diagnosis. The preliminary workup should include things that are commonly associated with anterior uveitis. So we want to get routine labs. We also want to look for TB and syphilis, so you get a VDRL and a Mantoux test. You also want to get a chest x-ray. So that's going to help you not only detect if there's active TB, but also if there's sarcoidosis. And sarcoidosis has a very high association with anterior uveitis. Some physicians will also get a serum calcium or an ACE level, angiotensin converting enzyme level, because those are associated with sarcoidosis, but I think a chest x-ray is enough. Other tests you can get as indicated by your history and physical exam findings. So for instance, if you think the patient may have ankylosing spondylitis, you can get a spinal x-ray, look for that bamboo spine. Some physicians will just go ahead and order that because of the association, but I think you can, the symptoms of ankylosing spondylitis are pretty discrete, so you can order that as needed, in my opinion. All patients with suspected anterior uveitis should be referred to ophthalmology. Anytime you have a painful eye, you should really think about referring to ophthalmology. And they're going to get a slit lamp examination, because a slit lamp examination is the best diagnostic test really for any uveitis. And then a dilated fundoscopic exam, and that will help you rule out panuveitis, because, well, you have anterior uveitis. How do we know we don't have posterior uveitis too? How do we know we don't have a panuveitis? We need to look at the retina. So that dilated fundoscopic exam will help you rule out panuveitis. Okay, intermediate uveitis we'll go over briefly. This is inflammation of the pars plana and the peripheral retina. The patient tends to present with decreased acuity, floaters, possibly cataract, but importantly, there's no pain here. Most commonly, intermediate uveitis is idiopathic, but there are immune causes such as inflammatory bowel disease, sarcoidosis, and MS. MS can cause intermediate uveitis. Infectious causes include TB and syphilis, as well as Lyme's disease. So multiple sclerosis and Lyme's disease stand out here uniquely in intermediate uveitis. The workup is pretty much the same. You're going to get a TB test, you'll get a VDRL, you should get a chest x-ray. as well as routine labs, and then other tests based on the history and physical. So you're really just going on what your common causes are. That's TB, syphilis, sarcoidosis, as well as some of these immune causes. All patients who have suspected intermediate uveitis, again, should be referred to ophthalmology for the slit lamp examination and for a dilated fundoscopic exam. Posterior uveitis is an inflammation of the choroid and retina. Here the patient tends to present with floaters and severe image issues, severe visual issues, so they'll have distorted images, decreased visual acuity, photopsia because you're affecting the nerve cells in the retina, and then rarely pain. Pain doesn't tend to be something you see with posterior uveitis. The symptoms of posterior uveitis are primarily visual. Most commonly, this is idiopathic. However, you can have immune causes, sarcoidosis, lupus, Behçet's disease, something called VKH disease, which I'll go over this in a little bit more detail on the next slide, and then sympathetic ophthalmia, which again I'll go over that in a little bit more detail on the next slide. Infectious causes, basically anything that can cause retinitis. So TB, syphilis, Lyme's disease, Bartonella, HSV, CMV, toxoplasmosis, toxoplasmosis. All of these can cause retinitis. They can all also cause uveitis, posterior uveitis as well. Your workup is going to be the same. You'll get a TB, syphilis test, get a chest x-ray to look for sarcoidosis, get routine labs, and then get any other tests that you think would be useful based on the history physical examination. All patients, again, with posterior uveitis should be referred to ophthalmology for a slit lamp examination and dilated fundoscopic exam. So that makes sense here because generally with posterior uveitis, on the differential, we're really thinking about retinitis too, so you're going to want to get a dilated fundoscopic exam from the get-go there. Okay, so here's some of these causes of posterior and also panuveitis that are a little less common, things you might not see as frequently. So this one is really uncommon if you're working in the US, and this is called Vogt-Kyanabi-Haraga disease, and this is most commonly seen in people of Japanese and Latin American descent. I don't know why. I guess they just have the genes for it. These people are not ethnically related, but that's who it tends to be seen in. And this is a systemic disease. So you see issues with the vestibulocochlear symptoms. You can have vertigo and hearing loss. What you really see most commonly, more of a hallmark of this disease, is pigmentation and hair abnormalities. So things like vitiligo, where you've got decreased pigmentation in the skin, patches of decreased pigmentation of the skin, poliosis, where the eyelashes are whitened, and then alopecia, where you lose patches of hair. You get ocular symptoms, not just posterior panuveitis, but retinal detachment as well, an exudative retinal detachment. And then systemic symptoms like headache and neck stiffness. So this is Vogt-Kyanabi-Haraga disease. And you'll really impress your resident ophthalmologist on staff if you know about this disease. Behçet's disease is a little bit more commonly known of because this is a joint issue that's commonly seen in rheumatology. This is an immune-mediated systemic vasculitis. And if you remember the mnemonic, can't pee, can't see, can't climb a tree, that will help you remember what Behçet's disease is. So can't see, that would be your ocular symptoms, panuveitis. You can also get episcleritis and conjunctivitis with Behçet's disease. Can't pee, that would be your genital ulcers and epididymitis, which would make it painful on urination. And then can't climb a tree, that would be your arthritis. So you get arthritis, you can also get skin lesions, very importantly recurrent oral aphthous ulcers, which are just canker sores, You can get intestinal ulcers, which can ultimately cause bleeding in the stool, and then neuropsychiatric symptoms. That's also known as neuro-Behçet's disease, but that can come with Behçet's disease as well. So ocular, genital, and joint and mucosal symptoms. That's what you should remember here. And then sympathetic ophthalmia is an interesting disease. So what this is you get trauma, penetrating trauma to one eye. So let's say you got stuck with a pencil in one eye, and then 5, 6, 20 years down the road, you start to develop blindness in both eyes. You start to develop panuveitis in both eyes. Why is that? Well, when you had penetrating trauma to one eye, you introduced parts of the eye that normally are shielded from the immune system. And so when those parts then, by the penetrating trauma, were then introduced to the immune system, into the blood, you start developing antibodies to those parts of the eye, and that causes inflammation. And it will affect both eyes, even though you only need to have penetrating trauma to one eye. So the symptoms and manifestations here, interestingly, are similar to the VKT disorder. So you can get pigmentation and hair abnormalities like vitiligo, poliosis, and alopecia, as well as, of course, your ocular problems like retinal detachment, posterior, or panuveitis. So it's interesting that the immune system must be picking up on some of these like pigments, melanocytes, as well as parts of the eye. That's what the immune system is introduced to abnormally. So important to differentiate this from VKH syndrome. It's going to be that history of trauma, and it can be a remote history of trauma. It can be 30 years ago. As long as there's ocular trauma, the diagnosis is probably going to be sympathetic ophthalmia. All right. So how do we manage uveitis? How do we treat it? This is important. This is going to be primarily done by an ophthalmologist, but you should be aware of how it's treated. So there's 3 things that we do. Reduce inflammation and pain. That's going to reduce your risk of developing complications. Most important, which is, especially when you're talking about anterior uveitis, is glaucoma. You want to treat any infection, and that's important because if there's an infection there, it needs to be treated in order to get rid of the uveitis. And then you want to treat any secondary cause if it's detected, if it's present. So corticosteroids are the cornerstone of management for uveitis. And this is done as usually topical eye drops when we're talking about anterior uveitis, but in more severe cases of anterior uveitis, or if it's intermediate or posterior uveitis or panuveitis, you have to give either a local injection or systemic therapy. So eye drops can only be given for mild cases of anterior uveitis. If it's anything worse, or if it's intermediate or posterior or panuveitis, you're going to need to give an injection or systemic steroids. So things that you can give topically for anterior uveitis, you can give topical prednisolone, dexamethasone, fluorometholone, they rhyme. If you need to administer something more systemic, of course you can give oral prednisone, IV methylprednisolone. You can also give a periocular injection, usually triamcinolone is what's administered. Of course, anytime a patient needs to be on corticosteroids for an extended period of time, we're concerned about adverse effects, things like cataract, glaucoma, scleral perforation. If you're giving it systemically, we're worried about peptic ulcer, osteoporosis, diabetes, hypertension. So in those cases, you may want to give, if they need long-term therapy, you may want to give immunosuppressants instead, and that can be something like methotrexate or cyclosporine. No, okay, actually I put it on here already. Okay, so just recap that. Topical eye drops, only for anterior uveitis? I think that may be a board question. So topical eye drops, topical steroids, prednisolone, dexamethasone eye drops, good for anterior uveitis. But if it's anything else, if it's intermediate or posterior or panuveitis, you're going to need to do a local injection or systemic therapy, and that can be triamcinolone or prednisolone. And then, as mentioned, patients requiring long-term therapy can be candidates for immunosuppressants like methotrexate and cyclosporine. There's other drugs that can be given that you see elsewhere, like azathioprine, chlorambucil, cyclophosphamide, tacrolimus. These are a little less common, but those are also agents that can be used. Now, in the case of anterior uveitis, remember that we also have pain, and we want to address that. So what we give is drugs that have both dilating and paralyzing effects of the ciliary muscle. So we call that mydriatic cycloplegics. They dilate the eye and they break down, or they paralyze the ciliary body. And by doing that, by dilating the pupil, it's going to help you break those synechiae. It'll pull them apart. And then the cycloplegic aspect, by paralyzing the ciliary muscle, it reduces ciliary spasm, and that's caused by the inflammation, and that's what's behind the pain. So both aspects, the mydriatic aspect and the cycloplegic aspect, are important to treat the uveitis. So you can get rid of the synechiae, and you can also provide some pain relief. So some drugs that are good for this would be something like cyclopentolate. You can also give tropicamide. You can give atropine. They all have, they've got varying lengths of how long they work. So if you're using tropicamide, that usually only lasts like 3 or 4 hours, so you need to keep taking drops. So usually cyclopentolate is the best. It works for about 24 hours, 20 to 30 hours, but usually it's something you can take daily, and that's generally the best choice. But there's lots of drugs in this class, but cyclopentolate tends to be what's prescribed most commonly. Okay, you'll also want to treat any infection, and so this is why we're doing that workup, looking for TB and syphilis and possibly Lyme's disease, or if they have posterior uveitis, looking for herpes virus, looking for CMV if they're immunocompromised, etc. So this is important because if you just go ahead and give the patient corticosteroids and they actually do have an infection, well, you just knocked off their immune system, and now their infection is going to get worse and their uveitis is going to get worse. So it's really quintessential that you know if there's an infection there before you start going ahead and giving the patient corticosteroids. You need to rule out infection. So this doesn't really have a whole lot to do with the eye, but tuberculosis, you would give the patient anti-tuberculosis regimen. Syphilis, you give parenteral penicillin. Lyme's disease, you give doxycycline. Unless it's a child, then you would give azithromycin. If it's ARN or PORN, you give IV acyclovir. If you want to know what that is, go back to the retinitis section. If it's CMV retinitis associated, then you give IV ganciclovir. If it's toxoplasmosis, then you'll give pyrimethamine and sulfadiazine. If it's toxopsoriasis, you'll give mebendazole. So I would say that if you have a patient that has uveitis and it's infectious, you'll probably want to be in consult also with an infectious disease specialist, because the question becomes, at what point do we start giving the corticosteroids after we've been giving the antibiotics for so long? You don't need to be aware of that for USMLE. What you do need to be aware of, though, is that you don't give corticosteroids until you've addressed the infection in some way. And then, of course, treat secondary causes if present. This may require a referral, depending on what the secondary cause is, to a rheumatologist, to a gastroenterologist, etc. Corticosteroids, though, are often the management for many of the systemic causes of uveitis, like inflammatory bowel disease or rheumatoid arthritis or ankylosing spondylitis or psoriatic arthritis. So corticosteroids are often used for those as well, or steroid-sparing agents too. So a lot of times there's some overlap in the treatment. Uveitis is a chronic disease in many cases, especially if there is a secondary cause behind it, like an immune cause, like inflammatory bowel disease, psoriatic arthritis, ankylosing spondylitis, JRA. And so in those cases, these patients will often develop multiple bouts of uveitis or have chronic uveitis. In sporadic cases like acute anterior uveitis, that may just be a once-in-a-lifetime event. So, but it's very important to know if there is a secondary cause, be it immune or infectious.